everybody. I'm Francesco del Galdo. I'm the chair of the Scleroderma Forum, and I'm very glad to be here today with Professor Zsuzsanna McMahan from Houston to discuss about ACR. We just came back. It was 2 weeks ago. It feels a lot longer than that, but it was so exciting. Zsuzsanna, hi. Thank you for coming.
Hi, Francesco. Thank you so much for having me. I agree. It seems like it was too long ago. It was such a great week.
Yes, and do you see how much scleroderma work is coming in the pipeline? It's incredible. You remember only 5, 10 years ago, it was such a different feeling, and now scleroderma is all over the place. What do you think?
I mean, you're right. Completely different landscapes, so many new, exciting, creative ideas for therapy, exciting prelim data suggesting response. And so, yes, it's a booming field, and there's so much great research ongoing right now.
Yeah. I remember when the only thing we were discussing was MRSS and a bit of prevalence and mortality. And now everything is coming up, including your special loved field, the gastrointestinal involvement. Yeah.
Yes.
In my picks, I selected two abstract. One was the your work, of course, and I hope you'll tell us about it. And the other one was the spring cohort, the analysis of the Italian registry. Have
Yes.
you noticed that? What do you think of the spring cohort analysis?
So it was really a great abstract. It was done by Francesco Bonomi and Silvia Belando Rondoni, who really led this work, but many, many authors included from across Italy. And they looked at a large cohort of, over 1,000 people with GI disease. And they tried to compare patients with upper versus lower GI disease, which I think is an important way to look at patients. And they also were able to show, which is very important in terms of validating some of the findings we've had in the US, that GI disease is not something that progresses from top to bottom, and that many patients will really predominantly develop lower GI disease over the course of their disease, and others will predominantly develop upper GI disease. And they identified several risk factors also for more severe GI symptoms, and some of those were vascular, which included telangiectasias, tobacco exposure, and duodenal
Exactly.
ulcers. And I think that's really important.
Yeah, I mean, you opened this field a few years ago, and I was impressed to see your clusters, and that made me think a long time ago. And I told you on a couple of occasions, it's like, what is it possible you think that what we call GI disease or severe GI is the equivalent of shortness of breath, and they are just different mechanism behind? If you look at the very old books of scleroderma, PAH and ILD were another thing. It was dyspnea, right? Are we there for GI? What do you think?
I mean, you labeled it so nicely, saying that this finding was really the pulmonary hypertension of the gut. And I do think that we are starting to understand these different subtypes better, and that it's very clear in the more limited patients or the more vascular patients for that matter, that GI disease, while it impacts the esophagus early, it's often the rest of the gut's not affected until much later. And it is suggestive that, especially in those with colonic dysfunction, that the blood vessel dysfunction played a significant role. And so I think it provides us with some insight into which groups to target for more vascular therapies, others to target for other types of mechanisms. And so I think we're getting closer using this risk stratification approach than we were previously, but there's still a lot of work to do.
Yes, there I entirely agree. It's exciting, and talking about mechanism now, your very one of the very last abstracts was perhaps one of the most interesting on the last day. There were a few selected people that remained there, but we were rewarded. Yeah, this new exciting potential mechanism for GI that you were involved with in collaboration with was a guy from NIH. Yeah. Can you tell
From
us a bit more? Yeah.
Sure. Thank you, Francesco, for those kind words. So, yeah, we were very excited to present our work. It was with Subhash Kulkarni at BIDMC. And we've been working for several years together trying to better understand different mechanisms of GI disease and scleroderma. And we essentially determined that there's a long story behind it, but that anti-mitochondrial antibodies are enriched among patients with more severe GI disease. So if you take all comers with scleroderma, it's only about 3 to 5% of patients, but in a GI enriched cohort, it's about 13% of patients. And we found that the antibodies associate, the anti-M2 specifically, antibodies associate with more severe esophageal motility and gastric emptying delays, and that the titers of the antibodies inversely correlate with transit in both of those areas. And furthermore, we determined that the antibodies to M2, which is also known as PDC-E2 or pyruvate dehydrogenase complex E2, that yeah, it's a mouthful, that they can go into cells, bind to this specific antigen at the mitochondria and impact cellular respiration. So we're hopeful that we can identify more of these mechanisms present among our patients so that we can have more precision medicine and targeted therapies that impact natural progression of disease.
Amazing, amazing. And I think, no, besides this being so original, one of the first studies in mechanism of GI, what I found particularly interesting is that it's supporting the notion that we ignored for years, that patients with vascular manifestation, they have an immune-driven disease. And also this is coming from different work, different parts of the world. And for this purpose, I selected another abstract, which is the Minimize pilot, where the group from Lawyer Free, led by Chris Denton, looked at the feasibility of targeting limited cutaneous scleroderma with mycophenolate, and not going too far with drugs, but we're one of the few drugs we know it works. And very timely, they invented this time to clinical significant event. Do you think trials are changing now in scleroderma? If we use this new endpoint, can we include patients with limited disease?
Absolutely, yes. I think you and I have both been seeing this field evolve from that standpoint. It's really exciting in that we are now including patients with limited disease in our trials, including other manifestations of scleroderma outside of the skin and the lung, hoping that we not only stop progression in those areas, but impact the disease globally. So I think the Minimize trial even though they didn't meet recruitment, was a really exciting step in that direction and showed the safety of MMF in that patient population.
Yeah, and I think it laid a great message out there that we can start to think trials in a different way. And I think we will start to see trial with time to clinical significant event as an endpoint. And that can really start to change the field, being more inclusive for our patients. Great, thank you, Zsuzsanna. But that one block, right, all this interesting vascular work. And then there was another big block, CAR-T. It was all over. Sjogren, lupus, and scleroderma was not immune. What do you think of CAR-T? Is it really changing the field? What's your personal opinion? I know we don't have data. We have more press releases than patients treated so far. But your personal opinion.
Yes, very well said. So that being said, even though data is still limited, I am excited about CAR-T. I think it's a first step of many in the field of cell therapies for patients with scleroderma. And while it's logistically complicated and can be quite costly, there is definitely promising data that suggests that we can at least stabilize disease in some patients. Maybe not the cure that we see in lupus, but you never know with larger trials what we may see. And it's really exciting that we're expanding beyond the targeting of B cells into other targets with these cellular therapies. Were you able to see any of those abstracts, Francesco?
Oh, yes. Actually, to me, I mean, CAR-T is a bit like rituximab. We borrowed from the hemato-oncology field, where they started to kill B cells because they were cancer. And then we noticed, I remember actually I was in training when the first case report of patient treated with rituximab because of non-Hodgkin lymphoma and concurrent rheumatoid had an improvement of their swollen joint count. It was, wow, do B cell really contribute to rheumatoid? It was, I don't want to tell my age, but it was before 2000, yeah. Anyway, and then we borrowed that, and the rest is history. And I think the same is happening here. The hematology field improved from monoclonal to cellular therapies, and we're doing the same. But the real excitement is that we can be precise in targeting cells that we don't like with a CAR T approach. And this, of course, can be B cells, but can be other cells. So there was an abstract targeting CD206, yeah, this specific cells that have been involved in the pathogenesis of tissue fibrosis. And besides, I mean, these are macrophages, but besides going into the details of that specific abstract, I think the field is potentially open now. Once we identify by single cell, by proteomics, a cell marker or a specific cell type that we think is crucial, then you can develop a CAR T therapy against that. And we can start to have a bit of a sniper approach rather than going with bombs and have this immunosuppression. The other CAR T interesting approach I saw is the CAR T reg. Yeah, it was
Oh,
the
yes, that's so
late break,
exciting.
exactly
I
the
mean,
late breaking
really,
aspect.
yeah, to decrease side effects potentially without the killing of, the bad cells,
Exactly.
putting them to sleep instead.
Exactly, and in vivo CAR T. So in general, having the ability now of targeting specific cells or inducing tolerance against specific targets, it's surely moving the field. Whether this will remain a remit of very severe multi-refractory patients or can be pushed earlier on the left of the natural history, it depends really on the safety. But yeah, I agree with you, it's an exciting field. Well, all right. And one more thing I want to discuss with you
Yeah.
because you are such an expert in these big cohort studies. When we wrote the recommendations, we defined the vascular therapeutic continuum, and
Yeah.
because the same drugs that work in digital ulcers work in pulmonary arterial hypertension, so it was not a big invention. And
Yeah.
there were only very few studies, but now there was another abstract showing the association between vasoactive therapy and reduced detection of PAH in scleroderma, again from the user registry, by treating patients with digital ulcers with bosentan and sildenafil, you actually reduce the risk of developing pulmonary arterial hypertension later on. And so it's showing again that there is a vascular disease and you spot it in the fingers before anywhere else, but eventually by treating the vascular disease that manifests in the fingers, you may prevent the clinical onset of PAH. And this will come back to GI, will come back to those patients that may have a
100%.
vascular involvement and 100% involvement of the gut. So
Yeah,
exciting
and I
time.
think that's very exciting. And I think to your point, the prevention of PAH is something that we've really only aspired to. And in fact, we've treated it after diagnosis, really until now. So the idea that this could be a new concept to move forward is a great idea. So yes,
Yeah,
and we should apply it
yeah,
in GI.
absolutely. So if you think now going back to GI and vascular, if you for PAH we have right cut, and after we finally learned what was the threshold, the consensus expert moved it left, and instead of 25 is 20, and this is happening in every field. For what you have seen in GI, if you needed to detect GI early, something to prevent before patient end up on parenteral nutrition or nutritional support, what should we study? Should we go like the IBD field and having endoscopies and imaging? Should we look for the specific biomarkers? How can we detect early GI that is about to become severe?
Yeah, so that's a fantastic question. I think it depends on the subset of patients. I think if you're speaking about the patients that really develop later lower bowel disease in the more vascular group, Julia Bandini, who I believe is now doing an internship with you, is doing some really exciting work with GI ultrasound. And she's been able to show that the splanchnic circulation has impaired reserve capacity. So blood flow is usually fairly normal at rest, but when there's a need to enhance blood flow in scleroderma, that does not always occur, which in theory could lead to long-term damage and or dysfunction.
Awoman.
So That would be one really exciting way to do
Yeah,
that
when I
in
can
that
target
subset of
things.
patients. Yeah, yeah,
Yeah, like the Davix of the gut, the digital artery voluminous of the gut. Makes sense. Well,
yeah,
great. Okay, so more to come, and we have the World Scleroderma Congress in a few months, so we see what's happened in between. Well, I don't
yeah.
want to take you any longer. Thank you so much, Professor McMahan, for joining us today. And ACR is clearly your turf, and I enjoyed this year, and Chicago was nice too. So I hope you come back to see us on the Scleroderma Forum soon.
Thank you, Francesco, and thank you for coming to ACR. Always happy to have our European colleagues.